So let me move on to meniscus transplantation. So again, food for thought, similar to what we had talked about, osteochondral allografts, meniscus transplant, same thing. You can start your own program at your own university or larger trauma center if you have organ donors. So a little bit of meniscus function. You all know meniscus is important, especially the lateral meniscus. It transfers a lot of the joint forces actually. So lateral meniscus 70% with the knee extension, medial meniscus a little bit less in extension, but especially in flexion, most if not all the stress gets transferred through the menisci. And if you lose your meniscus, you have vastly increased rates of arthritis. So 30 to 70% of patients who had a subtotal meniscectomy will develop arthritis in their lifetime. And the risk, if you match them, same age, same gender, same weight, same everything, if you lose your meniscus, your risk of arthritis is 15 times higher. So that's why the easiest thing to do if you see a young patient, they have an ACL tear, they have this bad meniscus tear, a bucket handle, maybe that's been displaced for a couple of months, the easiest thing is to just cut that thing out. And initially I always tell my patients, you'd be much happier if we take it out because it's a really easy recovery. But then afterwards, we have problems. And if you do that in a 15-year-old and then they're 30 when they come back with arthritis, your options are a little bit limited. You can do an osteotomy, which we'll talk about next. But that's why really the focus has shifted more and more towards meniscus preservation. We had the meniscus lab yesterday. We have more tools to even repair radial tears. And I wouldn't necessarily be heroic in someone who's my age, I'm 53, but if I see a teenager or someone in their 20s, I will do almost anything to try and repair that. Might not always be successful. You'll have failures. You talk to your patient and say, look, we try and save this. Maybe the success chance is only 50-50, but if successful in 50%, you keep your normal meniscus, your arthritis risk doesn't go up much. And if you're the 50% it failed, then at least we tried, we do another surgery, but that surgery will be very easy. And most patients understand that and agree with this. These are old studies, TEC scan, pressure loading. This was by Brian Cole and Jack Farr many years ago. But if you look, anything that becomes more yellow, more red is higher pressure. Normal meniscus, when you get rid of the meniscus completely, so subtotal or total meniscectomy, red is super high pressure concentration. That's what gives you arthritis because you locally overload the cartilage. And then in this case, they looked at what happens if you do a meniscus transplantation with a bone bridge. It's not normal. You can never make them normal, but you can make them much better. So there's still a yellow and orange, but there's a lot more blue and green than you had here. So they become near normal. Unfortunately, if you lose your meniscus, even if you do a meniscus transplant, they still have arthritis rates that are elevated compared to matched controls, but less than if you didn't do it. And more so than the arthritis risk in 10 or 15 years, they feel better while you have it. Because you put cushion back in. If you look at patient satisfaction after meniscus transplants, it's actually very high, and we'll get to the numbers in a little bit. So what are the contraindications? When don't you do a meniscus transplant? Well, if they have arthritis, that doesn't work. And there are many studies that have looked into this. It becomes a little bit more tricky. What is arthritis? Because they may have some cartilage damage. In fact, most of these patients have some fissuring, cartilage defects, but is it arthritis? If you get an X-ray and you see joint space narrowing, I would be a little hesitant, especially if they have more than 50% joint space narrowing. If you see joint space narrowing, think osteotomy, not so much meniscus transplant. If the X-ray looks good and you get an MRI scan and they have a cartilage defect, so more the pothole that we had talked about before, the studies show that meniscus transplants also don't do as well unless you fix the pothole. So you can do concurrent surgery where you do a meniscus transplant and you repair the cartilage, and you stabilize the ACL, and you do an osteotomy. So you can address all these things at the same time, or you can start with an osteotomy, see how well they do, and if they don't do well enough, that you can come back and do a meniscus transplant later. What do I use them for? It seems obvious, but meniscus deficiency. So this is not something where I see a patient who has a meniscus tear, even if it's a large meniscus tear, where I would say, oh, we go in, we take your meniscus out, we put a new one in. I've never done that. You do the meniscus, either a meniscus repair, you do a meniscectomy, and then if they come back and say, I still have pain, and it is weight-bearing pain over the joint line, it's usually not sharp. Sharp pain is more from a current meniscus tear where they pivot and it hurts. Meniscus deficiency is more if I walk too long. If I walk a kilometer or 2 kilometers, then it starts to increasingly be achy. It's like a toothache. I don't like it. That is kind of meniscal deficiency type pain. The analogy that I use is if you're used to walking in nicely cushioned sneakers and all of a sudden somebody takes your sneakers away, you have to walk barefoot on hard floor. It hurts. It's just this achy, uncomfortable pain. That's the indication for meniscal transplants. There's a sub-indication, ACL deficiency. Now that has nothing to do with pain, but if you look at the risk factors for repeated failure of an ACL reconstruction, meniscus deficiency, especially medial meniscal deficiency, is a risk factor. And why is that? Because the medial meniscus is a secondary stabilizer right after the ACL, and there were studies that looked biomechanically. If you don't have an ACL, you increase the stress on the medial meniscus. So if you look at chronic ACL deficient knees, they tend to over time get posterior horn medial meniscus attritional tears. And the reverse is if you have an ACL but you don't have a medial meniscus, there's more stress on the ACL, they have higher failure rates. I've never done a primary meniscus transplantation with a primary ACL. The meniscus is too big an operation to do that as a primary, but certainly if they come back, they've had 3 ACLs already, they don't have a medial meniscus, that's the situation where we would start thinking about doing a concurrent meniscus transplant with a revision ACL. So we said there are easy situations and there are a little bit more difficult situations in terms of when to do this. So, well, when do you do a meniscus transplant? How much meniscus needs to miss before a meniscus transplant is better than what you've left? Because we said meniscus transplants are not perfect. They're biomechanically not the same. Remember that TEC scan study, it looked better, but it didn't look normal. So if you have a situation like this, medial meniscus, you can see the medial tibial plateau. It's a very rough rule of thumb. If you look into a medial compartment and you can see the medial tibial plateau, a lot of meniscus is missing. The lateral is a little different because in a figure of 4 position like this, you can look under the meniscus. But by and large, in a medial meniscus, you never see the edge of the medial tibial plateau. So officially, if you have less than 5 millimeters of rim remaining, that constitutes medial meniscal deficiency. And it needs to be a continuous rim. So if you have a segmental defect, like a radial tear, even though technically you might have a lot of meniscus left, like in this case, this is a lateral meniscus, you see the popliteas. All the meniscus is in the knee, and this is one I repaired, but if you can't repair that, they have no meniscus function. They may have all the meniscus left in their knee, but similar to a posterior root tear, if it's not attached, it doesn't do anything. So if you have a complete irreparable radial tear or less than 5 millimeters of a continuous rim remaining, the thing doesn't work. So when do I transplant? Symptomatic patients, we talked about this. Same-sided pain, it seems like an obvious thing, but a lot of patients who had ACLs and something hurts in their knee, you want to make sure that what hurts is actually the missing meniscus and not they have some scar tissue, they have IT band, they have maybe donor side morbidity from their patella tendon or quad tendon harvest. So it really needs to be, this is dull and achy for medial meniscal deficiency. So what about the young asymptomatic patient? I said I don't take old meniscus out and put new meniscus in at the same time. But I get sent these patients sometimes even with still the stitches in, where somebody tried to repair a meniscus, it didn't work, they took it out, they realized that that's not a good thing, and then they sent them to me and say, consider this patient for a meniscus transplant. I never do a meniscus transplant at that time because it is a big operation. You just took out meniscus a meniscectomy patient is usually a pretty happy patient because now all of a sudden they feel good, they don't have that catching and clicking and pain anymore. And now you're telling the 16 or 17-year-old patient who's 2 weeks, 3 weeks out from surgery and feels good, might have started to go back onto the soccer field, that now we're doing a meniscus transplant and now you can't play soccer for 9 months. They think you're crazy. You need to have patients a little bit more aware that they have a problem, and they need to feel that they have a problem and not just hear that they have a problem because you tell them. So for these young asymptomatic patients, I usually get an MRI scan. I show them you don't have a meniscus, but you still have good cartilage, hopefully. And then I talk to them and their patients what to look out for. So the pain that we talked about, swelling, and I say you have to be honest to your parents and to yourself. And if you get some swelling, if you have a hard time telling where your kneecap is, and if this happens every time you play soccer, it's not a good thing. We get another MRI scan, you see an effusion, maybe you see a little bit of signal in the subchondral bone or cartilage wear. And if you see them a couple times over the course of a year or 2 years, at some point they will ask you for the meniscus transplant because they realize that they have a problem. And then you'll have a happy patient, even if the rehab is not so easy. We talked about the instability and failed ACL, so not doing it for a primary, but for revision, I think that is not a bad idea. Here, that's the situation again. You can imagine if you scope this person, you'll see the lateral tibial plateau because they essentially have no medial meniscus. And then the role of osteotomy, as you'll see in the next talk, I love osteotomies. I think you should consider most patients who are malaligned for an osteotomy. And if one of these patients come in and they're not malaligned, I'm always a little sad because I know an osteotomy can help them so much. On the lateral side, if you think about what the knee is shaped, if you look at a sagittal MRI scan of a knee, the tibial plateau is actually convex. And then you have the femoral condyle that's convex. So you really have two balls trying to balance on each other in the lateral knee. So the area where you have low transmission from the femur to the tibia is really small. And if you put a meniscus around that, then all of a sudden that area gets much bigger. So the lateral side is really dependent on the meniscus. So the threshold to do a meniscus transplant in addition to an osteotomy, that threshold is pretty low. If you think about the medial side on the other hand, so your femur still convex, but if you look at the tibia, it's not convex, it's a little concave. So the medial side, even without a meniscus, fits much better. So the load transmission area, if you call it, is much bigger. So if someone is malaligned in varus on the medial side, I usually just do an osteotomy and I don't do a medial meniscus transplant because an osteotomy is for life. It's bone. Once it heals, they can't screw that up. A meniscus transplant, if they want to go back to playing soccer, they can tear the new meniscus just as much or more than the original meniscus. So that's why the medial side here, I'm not quite as aggressive with meniscus transplants on the medial side than the lateral side. So the easy decisions, if they are youngish, and as I get older, what young means changes. If they had a total meniscectomy, so the whole thing is gone, because then you know you can make it better. We talked about pain on the same side, not that they come and have maybe IT band and not pain from their missing lateral meniscus. It should be intact cartilage, ideally, or you fix it at the same time. And then we talked about the ACL with medial meniscal deficiency. What's much more difficult is they have partial meniscectomy. So yeah, you lost some meniscus, but is the meniscus transplant really going to be better than what you've left? In those cases, maybe don't do a meniscus transplant. Go back to the osteotomy. Cartilage defect, we talked about repairing it. And then if they're asymptomatic, I wouldn't jump into that. Treatment algorithm, I said laterally, I'm a little bit more aggressive. If they're symptomatic, you transplant them, do osteotomies if they are malaligned. If they're asymptomatic, I watch them really closely because lateral meniscal deficiency, especially in young women who are maybe a little valgus, I've seen them progress to cartilage defects and arthritis really quickly. I remember a couple girls who were 14, by the time they were 16, they had bipolar cartilage defects. Can go really quickly. The medial side is a little bit more forgiving. If you take out a medial meniscus and someone is fairly well aligned, they might not have a problem for 20 years. So lateral, I have them come back. I talk a lot medial, I talk about what they have and then say, come back if you need me. So much less concerned medially. In terms of preoperative planning, it's actually pretty simple. We've looked at CT studies, MRI studies. None of them really were consistently better than this very old method called the Pollard method. Unfortunately, this doesn't come out all that well, but you take a regular AP X-ray, you just measure the distance between the tibial spine and the edge of the tibial plateau. You make sure that you have your magnification from the X-ray. So this is millimeter for millimeter. That's pretty easy. The AP distance, a little bit more difficult. You can see the posterior edge pretty well, but the anterior edge, there's a lot of variation in the anatomy. So a little bit of that is an educated guess. You take that length and then you multiply that usually by 0.8 for medial meniscus, 0.7 for lateral. But you can look that up. It's the Pollard method. And like I said, these have been as good as MRI. And then the three basic techniques, how you do it, and those techniques just vary in what you do with the root fixation. So you can do soft tissue only. That's the easiest. Most European surgeons, the Italians, the Belgians, do soft tissue only fixation, and their clinical outcomes are actually really good. If you look at biomechanics studies in the lab, bony fixation, so whether that's bone bridge or bone plug fixation, has been shown to be mechanically much superior. It's a lot more difficult doing it in the OR. So I'm always torn between, well, the Italians and the Belgians have good results doing soft tissue only, and it's much easier. But I did a biomechanics study myself, hoping that it would show that if you do a good soft tissue fixation, it's as good as a bony fixation. That's what I wanted to show, because then I would have felt good about doing what the Italians do, but unfortunately it didn't. Unfortunately, it showed that bony fixation is better, so I do a bone plug fixation. The first step is always the same. So you prepare the bed, you take out the native meniscus, because you want to, like any meniscus repair in the red zone is much more successful than anything in the red-white or white-white zone. So you really want to get back to the capsule, but you don't want to go through the capsule because you need something to repair, to suture the meniscus too. So take your biters, take small shavers. Don't go with like a super aggressive 5.5 bone cutter, because especially if you have good suction, you stick that in, and the next thing you know is there's no capsule left. So you want to get close to the capsule, like here where you see bleeding, so that you get that to heal. You debride the horn, the footprints, and then oftentimes a notchplasty, not the typical ACL notchplasty that's in the front of the notch, but kind of down at the bottom, maybe trim the tibial spines down a little bit, just so that you can pass the posterior plug to get posteriorly, because that can be very annoying. And be liberal on the medial side with doing an MCL pie crusting so that you can open up that space a little bit and pass the graft. So for the bone bridge technique, this is what the graft looks like. You have the meniscus, you have a traction suture here at the popliteus hiatus, and then you leave a bony bridge, and then you create a slot that corresponds. There are all sorts of proprietary instrumentation. Arthrex has one. You put a pin in, you ream over it. It's a little scary because you put a pin aiming right at the neurovascular bundle and you ream, and especially in the beginning, don't ream through the posterior wall. That's a little bit too scary. Once you've done a few, I always ream out the posterior wall, but you want to really be careful doing that. Then you slide the meniscus in, slide that bony bridge in, and you can fix the bridge any number of ways. You can use an interference screw, you can use little sutures, you can use a suture anchor, just something so that you have some bony fixation that heals actually really well. And then the rest you fix like a bucket handle tear. The bone plug technique, that's what I use mostly now, because bone plugs you can use medial and lateral. The bridge mainly use laterally, because when you look at the medial side, if you draw a line between the posterior and the anterior footprints of the medial meniscus, that line actually goes through the medial aspect of the ACL footprint. So if you want to do a bone bridge medially, you have to get rid of a little bit of the medial sided part of the footprint. It's about 25%. It's not terrible, but you don't feel good about that. While if you do plugs, you go in front and behind the ACL so you don't interfere with the ACL at all. So bone plugs, and then it's sort of like a root fixation. You can see in this old graphic how you pull it in. The same aiming guides that you use for tibial ACL tunnels you can use for this, or the guides that we saw yesterday for root repairs. And then we said peripheral fixation, that's just the same guidelines, what you do for a bucket handle meniscus. And as we talked yesterday in the meniscus lab, I tend to use all inside devices posteriorly so that I don't have to make a large approach posteriorly to access the posterior capsule. The body, I use the long double-armed needles, or you can use an outside-in technique. And then anteriorly, that's where I use the outside-in technique with spinal needles and a PDS. How many sutures? I've heard some people use 20 sutures. There's no meniscus left if you put 20 sutures in a meniscus, so I'm not a huge fan of that. I think it makes people feel good in the beginning. So 6 to 8 sutures is fine, usually 1 or 2 in the posterior horn, 1 usually in the anterior horn. That's the fat pad that heals really well. I've never seen it not heal in the front. And then for the body, you use probably 4 sutures. So like I said, similar to a bucket handle meniscus tear. This is a MRI scan 6 weeks after lateral meniscus transplant. This is the lateral meniscus. I picked the nice looking MRI ones. At 6 weeks, they look actually like a real meniscus, so you have this nice black signal. If you look at longer term, let's say 5-year MRI scans of meniscus transplants, they virtually never look normal, but they still function. So they look a little bit more degenerate, a little wider. They don't have that nice black signal, but patients are quite happy. So the return to activity for me is at least a difficult problem. These are young patients. They all want to go back to playing soccer or basketball, but that's how they tore their meniscus in the first place. So Brian Cole had looked into this. Approximately 25% of an acute failure risk, so failure in the first 2 years if they go back to high cutting sports. People just need to be aware of that. And one way that now I pose that issue to them is more, you can go back, it just depends on how important this is to you. If you go back and you tear it and you sit in my office and we talk about you needing more surgery, if you say, well, at least I tried, I love the sport so much, it was worth it, then you go back and we'll see what happens. On the other hand, if you think that sitting back in my office, you would be angry at yourself and say, why did I do it? It wasn't that important, I shouldn't have done it, then the sport is not important enough for you to go back and then find something else. These are clinical results. We don't have to look at this, but in terms of summary, by and large, if you look at 10 years, about 75% of meniscus transplants are still functioning structurally intact. Interesting enough, even though it's just 75% that we would call structurally are intact, 90% of patients are actually happy. So even some patients who technically have a failed meniscus transplant, when you ask them if they would do it again, 10 years later say, yes, I would. They might not have gotten 10 years out of it, but they might have gotten 5 years or 7 years. And as long as for them, what they put in terms of pain of the surgery, annoyance of the rehab, recovery, as long as they get out more than what they put in, and that's a very individual decision, every patient's a little different, but most of them were happy with their decision, would do it again. So in terms of patient satisfaction, it's actually a very good operation. These are friends of ours, Al Getgood, he's from London, Ontario, and Bill Bugby is from San Diego. They've done this paper together where they look at combined meniscus allograft and osteochondral allograft. Oh, this is, by the way, the post-op x-ray of what a lateral tibial plateau osteochondral allograft looks like. So 2 screws fixed, this is well healed, joint space is maintained. So similar, 90% of patients who have these really complicated procedures of meniscus and osteochondral allograft and long recovery are still happy and would do it again. So meniscus transplantation is really for symptomatic meniscal deficiency, not just because you don't have a meniscus but otherwise feel happy. That would be a prophylactic transplantation that's controversial. So yes, I tell my patients, you don't have a meniscus, this is what you need to look out for, but I don't say you must have surgery. That makes for unhappy patients. Like anything else, look at the comorbidities, so cartilage, ACL, especially alignment, and then about 75% of grafts are intact at 10 years. And as I mentioned before, it's better than not having any meniscus, but it's not as good as having a normal meniscus. So it slows it down, but it doesn't stop the progression to eventual arthritis. So all of these patients, you will have another surgery. I don't know if it's in 5 years, maybe a little trimming of the meniscus, in 10 years, removing of a larger part of the meniscus, or in 20 years, a replacement, but you will have another surgery if you start this process at 15 years or 20 years of age. Questions for this now, because otherwise I have like a 2-hour monologue and I sort of get bored listening to myself. So why don't you drink something and think about some questions. And if you don't have any, I'm perfectly happy to keep talking, but you don't need to keep questions till the end, where then you only remember that you had a question, but not what the question was. No? Good. Osteotomies. I thought this is sort of a combination of an exciting and a story and a little bit of a scary thing. Who of you does osteotomies? High tibial, distal femoral. Good. HTO. Good. Osteotomies are great. The concept is really scary. I said before, if you talk to a patient, I'll take the saw, I'll cut through your femur or tibia, and then we fix it, and lots of screws and plates. Most patients will say, thank you, but no thanks. And surgeons are pretty scared about that too. So we tend to do a lot of osteotomies. But for example, I spent 20 years at one of the Harvard hospitals in Boston. We had 12 residents a year. They rotated through 4 hospitals. They do residency for 5 years. The only people who did osteotomies were Tom Minus, who was my partner, and myself. That's it. So since not every resident rotates with us, if they rotated with us, they saw DFOs, HTOs, TTOs, they felt comfortable doing it, they did them. If you didn't rotate with us, you saw no osteotomies. And once you're an attending, then to all of a sudden start a procedure new that you've never seen, that you never had a chance to do with someone watching over your shoulder and holding your hand, that's a hard thing to do. So if you look at the utilization of osteotomies in Europe, is way greater because people do osteotomies, so the residents see the osteotomies, so they will do the osteotomies when they become attendings. And the reverse is true in the United States. Most residents either don't see osteotomies or very few, and then talk themselves into doing knee replacements and 30-year-olds, because knee replacements they see a lot, so more comfort. This talks about all the scary things that can happen and how to make sure that they don't happen. So this is pretty easy. Who do you consider for an osteotomy? Medial compartment pain is the most common one. So medial opening wedge osteotomy, high tibial osteotomy is probably, that's 95% of all osteotomies done in the US are medial opening wedge. Medial pain can come from medial compartment arthritis, but it can also come from medial meniscus deficiency. We just talked about this. Medial root tears, for example, or they have cartilage defects. And you want to do your cartilage transplant, like the guy with the huge varus deformity that I showed you before. They're really coming in for the cartilage defect, but you say, well, unless we fix the alignment, we don't even have to bother fixing the cartilage. So sometimes it's an isolated osteotomy for arthritis. Sometimes it is to help whatever else you're doing, whether that's a meniscus transplant or your root repair or your cartilage transplant. Your osteotomy helps make that more successful. So this is one patient, for example. She had hypophosphatemic rickets, it's just a congenital vitamin D processing issue, and they're all pretty short, and they're all terribly varus. So this was her pre-op alignment. This is actually between her first, so she already had an HTO on the left, on the right, and in pre-op holding for an osteotomy on her left. This is another patient who is malaligned, who has meniscal deficiency, had pain. So there are a lot of different indications that you can consider. You can also consider it for ligament instability, and that's something that I would say 5 years ago, virtually no one talked about, and now all of a sudden you see all these papers coming out about posterior slope correction with recurrent ACL failure. So these are two cases. This was a patient, she's a state trooper, so policeman, and she already had 3 PCL reconstructions. She had a first transtibial, then she had a revision transtibial double bundle, which failed, and then she had an onlay, that's where the screw was from. And she actually has no posterior slope. If you looked at her, her posterior slope was 0. And then we did an anterior opening wedge osteotomy, didn't do anything to her PCL. And if you tested her, she was a little bit more stable just from the osteotomy alone, but more importantly, she wasn't symptomatic anymore. So we never touched the PCL again. So this was a supratubercle anterior opening wedge high tibial osteotomy. This is a patient who's the reverse. They had a posterior slope that in this case was kind of 12 degrees, which is borderline, but they already had 3 ACLs. They're going to do a 4th one. I did one, but you also have to do something else. And in this case, this was an anterior closing wedge. The anterior closing wedge for slope changing, I do below the tubercle, and I fix it with 2 Richard staples and a screw. I do it below the tubercle because then you can do your revision ACL above your osteotomy, and it's completely independent. It's especially useful because this is, I think, a patient that Sabrina and I did together. Just her patient, so she did the revision ACL, and I did the osteotomy, so she could do her part totally independent. I can do my part totally independent. Makes planning the OR much easier. So some people do the closing above the tibial tubercle. The reason I don't like that is there isn't much room above the tubercle, and if you take out 8 millimeters or so, then your proximal part gets really thin, especially if you already had 3 ACLs and you have holes in your tibial plateau. I'm overthinking this, but I don't want to get into complications, and I feel at least if I have a thin shingle and it breaks, fixing that is really hard. Problem number 1. Problem number 2 is if you do a closing wedge above the tubercle. So if you think about, let's say this was an opening wedge, but let's say this is a closing wedge. I took the wedge out and then you bring this down. That means you get patella alta, right? Because you bring the joint line down, you leave the tubercle, you leave the length of the patella tendon. So now you create patella alta. Might not be a problem if you do 5 millimeters, but if you do a centimeter, it makes a problem. And then somebody else at some point, we said all of these people will at some point have another surgery. They probably will have a knee replacement at some point. If the distance from the tibial plateau to the tibial tubercle now all of a sudden is just 5 millimeters, making your tibial cut for total knee is really hard. So if you want to be nice to who comes after you, don't do it above the tibial tubercle. If you do it below the tibial tubercle, you don't change patella position. You have plenty of bone up here, nothing's going to happen, but if something happened, you have enough bone to put screws and plates, and the total knee surgeon won't even know that you were there because your surgery was in a very different location, and you don't have to worry about it. So always be nice to who comes next. So who do you consider for osteotomies? Again, it's an easy decision if there are no other options. So if someone is really young, what's really young kind of changes, but certainly if you're less than 40, most of our arthroplasty colleagues are not super excited doing replacement, so that is pretty much osteotomy. If you're above 50, I have done them, but the recovery becomes more difficult. And the main reason to do an osteotomy, meaning you don't want to have multiple revisions of a replacement if you start young. If you're 50 or 60, you may have one revision that's usually acceptable. So it might be the easier pathway. But having said that, I've done osteotomies in patients in the late 50s and early 60s, but it's a longer discussion. It's something you really need to want that, and your complication risk will go up. If they have medial meniscal deficiency, I'm pretty aggressive, so more than 3 degrees, for me at least, means I start thinking about osteotomies. The more classic teaching is 5 degrees, but 5 degrees is kind of a lot. So I'm always, like I said, happy if I see enough malalignment to consider doing an osteotomy because the outcomes are really good. And once it's healed, it's like any other fracture. You just do whatever you want to do. You don't have to be careful about a meniscus transplant, or don't run because you have a replacement and might loosen out. you just run on it. Nothing happens. Like I said, it's a little bit more difficult when they're older because medial uni, which I also do, is a good operation. Contraindications, if you have something in the lateral compartment already, you have had a lateral meniscectomy, you have a posterior root tear maybe because you had an ACL and it wasn't treated, then it becomes a more difficult choice. Because if they're in a little bit of varus, they only have medial-sided problems, and whatever they have in their lateral compartment you may see, but they don't feel. If you do an osteotomy, then the lateral compartment may become symptomatic or break down, and then all of a sudden the revision option is not a uni anymore, it is a total. So you may make them worse in a way of what's the next step. Whereas if you do a uni, you can leave them in a little bit of varus, so whatever their issues in the lateral compartment won't get overloaded, may not become symptomatic, and they may be fine for 15 or 20 years with the medial uni. Disease in the patellofemoral compartment is actually not much of an issue. There are different philosophies. If you look at the Oxford school, in terms of the Oxford medial mobile-bearing uni, they will say patellofemoral disease doesn't matter. If you really ask them, they have certain criteria. Certainly if you have edema on an MRI scan in the trochlea or in the patella, especially if the problem is in the lateral part of the patellofemoral joint, then I would be a little careful, both with osteotomies and with medial unis, because both take someone out of varus, put them in a little bit more valgus, which means it puts a little bit more stress on the lateral patellofemoral compartment. So if they already have a laterally tracking patella and lateral patellofemoral disease, whether you do a medial uni or an HTO, you may make that worse. On the other hand, if they have medial patellofemoral compartment, like they have a medial patellofacet lesion and they're in varus, if you take them out of varus, because you sort of lateralize the tibial tubercle a little bit, then you make that better. So medial patellofemoral compartment, generally not a problem. Lateral, you need to think about it. You can, at the same time that you do an HTO, you can also do a TTO. So you can combine those. It just becomes a little bit more, becomes technically a little bit more challenging. That shouldn't be your first HTO, I would say. How do you plan it? I always get hip to ankle x-rays. Some people say you can do it on just a knee x-ray where you look at proximal tibial angle. But I've seen enough patients where the proximal tibial angle was one way, but then they had this funny twist in their femur. So you really need hip to ankle to plan this properly. And it's pretty easy. You have the current weight-bearing line, that's for your indication. If it goes through the medial compartment, for me, that's an indication to do an osteotomy. Then you drop one line from the center of the hip to the center of the knee, or at least where you want that line to be when you're done. You measure the angle between the two, and then you transfer the angle down here and measure whatever distance that means of how open the gap needs to be. Because we're not very good at measuring angles in the operating room, we're good at measuring distances. And where the line goes just depends on what they have. So if someone has a good meniscus, they just happen to have, let's say, an OCD lesion, all you want to do is you want to make them normal. So you put that weight-bearing line in the center of the knee. You don't want to overcorrect. If you do cartilage repair and they maybe had a little bit of a meniscectomy, so you want to help out that the meniscus is mildly deficient, then you put them over a little bit more, so go to the lateral tibial spine. And if you have someone who truly has arthritis and you do an isolated osteotomy for arthritis, you have to do a little bit more. I don't go into the lateral compartment, as Coventry used to say. People hate that. It looks weird. Lateral compartment breaks down. I usually keep it at the lateral tibial spine. And if you look at the clinical outcomes, there are more recent studies that said you actually can have good results with comparatively less correction, so to the lateral tibial spine versus the old thinking that you have to go into the lateral compartment. You can still get good results. Can you advance this one? It doesn't want to. No, there we go. And then pick the right osteotomy. I don't know where this is. Let's see if we get into timing. Can you rewind there? Yeah, this one's fine. So pick the right type of osteotomy. So I said before, 95% of all HTOs are pretty much medial opening wedge HTOs. But if you look 20 years ago, the vast majority were lateral closing wedge HTOs. I don't know why people started a lateral closing wedge, because everything about a medial opening is easier. That's why everyone does it now. Why are they easier? So your incision is either center or medial. And if you think what comes next, meaning either a uni or a total, you can use the same incision. A lot of the old lateral enclosing wedge were these weird hockey stick incisions or oblique incisions that you can't use for whatever's next. So, as I said, be nice to the person who comes next, and that's true for where you put your incision. You can titrate a medial opening wedge. You make one cut, you open it up, you use either a bovie cord or you use a rod with fluoro to the hip and then to the knee, and you open it up a little bit more, you open it up a little bit less, you can correct it. But if you do a closing wedge, you do two cuts, you take your wedge out, you close it down, you take an x-ray, and then you say either it's great or eh. So there's less of an chance with the opening wedge. That's why they're easier. And then last but not least, because with a lateral closing wedge, what you really do is you bring the joint line down. You have to do something to the fibula, because the fibula wants to keep the joint line up. So either you take a cob, you go into the tip fib joint and you pop the capsule so that the fibula head stays where it was, and you lower the joint line, but then your posterolateral corner is slack, which is not so great. Or you go down here and you do a fibula osteotomy, which is preferred, but the fibula doesn't like to heal, so you have to make a long oblique cut, probably fix it so that they don't get a non-union. But look at an MRI scan of the lower leg. The neurovascular bundle is right next to the fibula. It's hard to imagine not getting that if you cut the fibula. So that's why, by and large, the moral of the story is do a medial opening wedge and then pick the right fixation system. So this was the first generation stainless steel. Giancarlo Pudu was an Italian surgeon. He worked with Arthrex. They brought out that first one, non-locking screws. If you do this operation perfectly and you bone graft it and you keep him on crutches for a long time, this works great. If you don't do all of the above, this can totally fall apart, and I'll show you a case where it did. So it's much safer if you use the current generation of locking implants. The same way in trauma, you or your colleagues probably use, we do, fixed angle. It doesn't have to be titanium in 15 different colors, but just a stainless steel locking plate, it's much safer. Even if you get a little bit of another complication, which I'll talk about later, a lateral hinge fracture, if you have a locking construct, by and large, you're okay. So I don't see any reason to not use locking. If you have it available, they're more expensive. So that may be an issue. And then I'll show you a technique, what you can do just to make it more stable if you don't have locking plate systems. This looks scary. This is an eye balance. It's a all inside implant of a PEEK implant. That's why you don't see it. I love the concept. I don't use it, but what I love about the concept is that it goes inside the bone. You take your MCL off, you do your osteotomy cut, you open it up, you put the implant in, you put your MCL back over. There's nothing prominent. You don't take these out. That's great. This seems silly, but I just don't love what it looks like. I want an osteotomy to heal, bone back. I take the plate out and it looks at some point like no one has ever been there. And if you do surgery in 10, 15 years, you don't have to worry about anything. You just do your surgery. Whereas if you revise this and you put a uni on top or a total, a lot of arthroplasty surgeons say, well, I don't like how that looks either. I'll use a stemmed implant or I don't do a uni. So it may influence what comes down the line, and because many of these patients are young, I care what comes down the line. So how do we do it? So I said, be nice who comes next. Think about a total knee or a uni. So you can do a midline incision. Then you need a longer incision because you're working really on the medial part of the proximal tibia, or you do something that's a little medial to the midline. There are different ways how to handle the soft tissues. I'll tell you how I do it, but not saying that that's the only way. But this is like you harvest hamstrings for an ACL. So you incise the sartorius fascia, the forceps holds the pes right now, you can see the MCL. So that's my first step. Then I cut it, so still similar to a hamstring harvest. Now you have this exposed, and I actually release this fairly far down. You don't have to do that necessarily if you do like a 3 or 4 millimeter correction, but if you do 10, then the soft tissues on the medial side get really tight because they attach distally, they attach proximally. It hurts and it makes the knee motion a little difficult. So by doing more of a release, you relax those soft tissues, it makes the rehab much easier. So now you're looking at the MCL, and then some people then peel off the MCL. I don't do that. I'll tell you in a second why. I incise the fascia at the posterior edge of the MCL. You'll immediately see popliteus underneath, and popliteus is your friend because popliteus is between what you do and the neurovascular bundle. So then you just develop this interval, and I usually put the patient in a figure of 4 position. I stand this side of the table, you look right in there, make sure you have good lighting. You put your pickups here like I have, and then with the Bovi, the electron knife, you stay on bone and you just slowly do this. Especially if you use the electric knife, the muscle kind of twitches a little bit. It sort of helps with the dissection. It almost pulls itself off the bone. And you don't have to do that all the way over to the fibula because the popliteus is really only attached to the tibia for about 2 centimeters. So once you're in 2 centimeters, then you take your finger and you go in and you can wiggle your way all the way over to the fibula. And ideally, you don't stick anything sharp back there. Your finger usually is enough, especially if you're more distal. The more proximal you come, the more muscle attachments you have to the tibia itself. If you're distal, so this is where we had cut off the pes. If you work in this area down there, there are no blood vessels, it's safe, and then you can, if you have to, work your way proximally. But first you find that interval, and then this is a pretty typical HTO incision for me. We did something intra-articular like an OCA at the same time. I don't do the whole sponge in the back anymore. I just put, this is, in the US it's called a malleable retractor. It's sort of 3-4 centimeters wide. You stick that in, that's what it looks like. And once you have developed that interval with your finger over to the fibula head, that slides in very easily. You don't need much, really. As long as you have enough space in the back to slide sort of 2 or 3 fingers in, you don't need more dissection than that. And this thing is what protects you. If you on X-ray see that this is almost all the way over to the fibula head and that your pin, which you cut along, is centered over this, it's hard to screw up anything. Not impossible, just hard. There are different techniques. I always use a biplanar osteotomy. That's not typical in the US. Usually people just do one cut. Doing one cut means that you have to cut above the level of the tibial tubercle, which means you're pretty proximal. And similar to what I'd said about this slope-changing osteotomy, where if you have less bone, there's a high likelihood that you get a fracture into the tibial plateau. I usually do a biplanar one, where this retractor is behind the patellar tendon. The tibial tubercle sits here, but my pin is actually below the level of the tibial tubercle, and I aim at the fibula head. Because you're working essentially behind the tibial tubercle, you have to do a biplanar because you don't want to come out in the tibial tubercle, so you do a countercut behind it, and that's what that looks like. So you do one cut down, and now the leg is straight, you're parallel to the floor, you go with a little saw. It's almost like you make a tibial tubercle osteotomy, you just don't go distal. You do just the proximal part come across until, if you put your finger on the lateral side, you can feel your saw coming out under the skin. And then you do your main cut going down along the pin. So you have your malleable. Here you can see the saw blade. It's essentially all the way over. You can see how much proximal tibia vera there is. So this was someone who has a lot of veras. This is the saw that I use. You just go along your one pin with the protector in the back, and then just make sure where you are anteriorly so that you don't cut into the patellar tendon or the tibial tubercle. I finish this always with an osteotome in the back, and the reason why that looks sort of so elegant is because I have my index finger at the edge of the osteotome, because that means that you don't have to take floor shots all the time. You have your finger touching the back of the tibia, the edge of the osteotome is on your finger, and you know that you put this thing in until the tip of your finger hits the fibular head. Then you know you're over, you're safe all the way along. You don't have to burn floor time all the time. That's ready for that yet. So osteotome, posterior cortex, saw for everything else. That keeps you safe. Do that in the beginning. What do we want to avoid? We want to avoid that. So we have your neurovascular bundle. I said the popliteus, this muscle, is your friend because the popliteus is between the tibia and the neurovascular bundle. And this is just word of caution because that is true for 98% of patients. About 0.2% of patients have a vascular abnormality that's called an aberrant anterior tibial artery. If you look carefully, you see this black here. That's the anterior tibial artery. It should be here, but in those patients, it bifurcates high, and then they have the vessel between the popliteus and the bone. I always look. Why do I look? Because my ex-partner, who described this in literature, described it because he cut it. So, and he is an excellent surgeon who does a lot of osteotomies, and he made his cut and was like, why am I looking at a lumen? And that was an aberrant anterior tibial artery. So when you plan an osteotomy, just take a look, make sure there's nothing here. Like I said, it's rare, but I've had 2 cases in the last year and a half where I ended up doing a distal femoral osteotomy instead of a high tibial osteotomy because of that. Now, if you want to do an HTO for these patients, just have a vascular surgeon there. Make a bigger incision, let them do the approach. I honestly don't know if when you take the popliteus off, for all I know, maybe the blood vessels fall away from your tibia, but maybe they're attached to the periosteum. I don't want to be the one finding out, so have vascular surgeons there. That can be their problem. This is a case of a patient where they made a nice and small incision in the front. Then after that, they made a big incision in the back because the vascular surgeons came later and repaired his popliteal artery. That's sort of the scariest thing that can happen in the osteotomy. But if you do the approach carefully, you look at the MRI scan to make sure that they don't have this vascular abnormality, and you put a retractor in, this is not going to happen to you. So we all worry about this, and as long as you worry about this, it's not going to happen. Got black toes too. But, once you've made the saw cut, once you did the osteotome and you're all the way over, well, you still need to open it up. Several of the systems have little wedges. So they're metal wedges. If you put a metal wedge in, the force concentration is right at the tip. And if you haven't done a good job cutting all the way across, so you can imagine if you put just a wedge in here, it's very easy for the forces to go straight up. So the gentlest, the best, the safest way is stacked osteotomes, where you put the first osteotome in proximally, all the way across. Now you have a hard support of the proximal tibia, and then your other osteotomes go distal to that. And by going distal, you spread the forces across the entire width of the tibia. It's not going to crack up into the tibial plateau, and you're safe. So stacked osteotomes, and the first osteotome has to be at the side of the knee. Everything else, you do distal to that. If you do it the other way around, it doesn't protect you. I had mentioned before, if you don't have locking plates, it's inherently less stable. Non-locking plates don't stabilize the lateral side. Locking plates do, because they're angle fixed. If you don't have fixed angle devices, you can do this, or I do this if I have large corrections. Because if you have a large correction, if you know that you're going to do 10 millimeters or 12 millimeters, 100% you will have a hinge fracture. It may be a stable one, but the hinge will crack. You open it up, and my PA always does this because at some point you'll hear a crunch. But if you know that you'll hear a crunch, you can make a small incision just lateral to the tubercle. You take a big, it's called Richard staple for us. These things are really cheap. You do one staple, you see where the osteotomy is. So before you open it, before you get a lateral hinge fracture, you put that staple in, just over the lateral edge of the tibial tubercle, and then you open it up. And that showed, there were mechanical studies that if you have a lateral hinge fracture and a non-locking plate, it reduces the stability of your construct by almost 70%. So it goes from 100% down to 30. That's a lot of instability. If you put a staple in, it almost restores the original stability of the construct. So just by adding a cheap staple laterally, you make this mechanically really stable. And if you get that crunch, you don't have to worry because you don't lose control over the lateral side. Because what can happen is if you have a large hinge fracture, now suddenly nothing is connected and the thing becomes really unstable. So that's why I do that before. And that same staple, where here, by and large, the tines were almost parallel. See what happens when you open it up. So the whole staple kind of bends open, and it kind of spring-loaded, so it gives you compression over the lateral side, and it heals much better. So if you have a big correction, adding the staple really helps. This is a little bit of a tangent, but even for tibial tubercle osteotomies, where you don't go posterior, you think you're far away from the neurovascular bundle, it's a safe thing because you do your osteotomy in the front of the knee. Always aim towards the medial side. Your tibial tubercle osteotomy goes this way anyways, so you should be perpendicular to the line of the osteotomy anyways. But I see a lot of patients who had TTOs elsewhere, and it looks like the surgeons almost had the pride to try and be as straight front to back as they possibly can, so that when you have an AP X-ray, you just see like a dot of the screw rather than looking at the screw going sideways. But this is a case where you just see sort of the shadow of the screw, and unfortunately it doesn't come out, but the neurovascular bundle is right there. So if you have a drill bit that's a little dull and you push and you push, and at some point you go and you plunge, if you plunge here, there's nothing there. You can plunge 2 centimeters, nothing. The semimembranosus is the only thing, and who cares? But if you plunge going straight front to back, not only do you have bad compression, so you don't want to do that anyways, but your neurovascular bundle is right there. Save yourself that headache. What other things can go wrong? Patella baja. So you see this case where there's hardly any space between the patella and the tibial plateau. If you send this to a total joint surgeon, they will curse your name, because getting that exposed so that they can cut the lateral tibial plateau is really hard. Sometimes they have to do a tibial tubercle osteotomy just for exposure. Why do you get patella baja? Because I said before, if you do a lateral closing wedge, you lower the joint line. So if anything, they get patella alta. But if you do a medial opening wedge above the tubercle, you raise the joint line, so you get patella baja. For the normal HTO, where you, let's say, do a 5-6 millimeter correction, it doesn't really matter that much, because if you correct 6 millimeters on the medial side, the tubercle is sort of halfway. It means 3 millimeters lower patella, no one really cares about. But if you do a large correction, 14, 16 millimeters, which is rare, in a patient who maybe has a little bit of patella baja to begin with, then all of a sudden you end up with that. How can you get around that? We said I do biplane osteotomies where I make a cut behind the tibial tubercle. 95% that cut comes from proximal. You can make that cut distal. So if you look at this patient, for example, this is the osteotomy cut, but then rather than cutting up here, which I usually do, you can cut distally, which leaves the tibial tubercle attached to the tibial plateau. So similar to those slope-changing osteotomies, this way it doesn't change patella height at all. The only problem is then you want to do one additional screw, almost like you fix a TTO. just to make sure, because the proximal bone is pretty soft and it could break off. Increased posterior slope is something that people have talked about opening wedge osteotomies forever. If you do a medial opening wedge osteotomy, everyone says you will increase posterior slope, which in someone who's a chronic ACL may make them symptomatic. There are a few ways to not increase posterior slope. You just have to be careful. So one, here you can see huge posterior slope. And that's because when you open up your osteotomy, you want to make sure that you put the most force posteriorly, so that when you open it up this way, not that way. And sorry, one really easy trick, I don't know if we call it paint roller. And when you position the patient, there's a side post, and then there's something on top of the table where you can put the heel against. Use that, make it a little higher, and have it so that it sits here, so that the knee essentially floats. So almost like someone picks up the leg by the heel, because that means the knee wants to hyperextend, which means your posterior slope will not increase when you do osteotomy. They're just little tricks with positioning. And then last but not least, we talked about these hinge fractures. It can happen with a distal femoral osteotomy, the same way it can happen with a high tibial osteotomy. We talked about the staples. If ever you worry, do either prophylactic staple, or if you haven't done a staple and you get this crack and you worry a little bit, put that staple in. It means that everything will heal much faster. Patients will feel much better. This year was a patient who had a distal femoral osteotomy, which I did. There was a crack. She said, oh, the outside feels fine, but 2 months later, it still hurt her on the medial side. We took her back to the OR. We added 2 staples, and 3 days later, she said, I'm fine. So there's a little bit of micromotion in these hinge fractures that can just hurt and delay healing. And like I said, a staple is an easy thing to do. I think we're getting to the end of this, because my voice is getting to the end of this. But I would say, besides vascular injury, and as I told you, if you are careful with the dissection, if you put the malleable, this will not happen. This is probably the second most feared complication, and that is a fracture into the tibial plateau. And this case was in the fellowship, when I did fellowship in 2005. And we hadn't sort of listened to our own advice. I said before, don't use those little metal triangles, go in with an osteotome, do everything after that below the osteotome. We did the metal triangles because it seemed the easiest thing to do. You put the triangle in, and all of a sudden, because we probably didn't do a great job making sure that we had done the osteotomy cut completely, we bent it up and it fractured right between the tibial spines. What you do in that case, you take your triangle out, you reduce everything so that the fracture, the tibial plateau fracture, is almost not visible, and then you fix it like a tibial plateau fracture. We put 2 rafting screws across on the floor. We went back with our osteotomes. We made sure that we really finished our osteotomy in the front, in the back, and then we did what we should have done to begin with, put an osteotome, did everything else distal to that, did autologous bone grafting so that it heals better, and the patient healed uneventfully. It's just annoying if you get this. There's a way out of it, but if you're careful with your technique, then you won't even see it. Non-union, personally, I've never seen it, but if someone is older, so those patients who, hey, I'm 60, I'm a marathon runner, I really don't want a replacement, I want an osteotomy, just make sure you check their vitamin D levels. They should be normal or high normal, which even in New York, people eat well, most everyone is low normal. In the Northeast, we don't get enough sun. Low vitamin D levels is a common thing. Just check it. If they're low, either you prescribe high dose, you can give 10, 20,000 units once a week, and don't do the operation before they're normal. This is, if you get that, this was an orthopedic surgeon from Brazil, that is a catastrophe. Like getting your way, I mean, you can't even do a knee replacement for this. So you don't want to get into that. So if you do larger corrections, let's say 10 millimeters and above, consider doing autologous bone grafting. We talked about the locking plates. I'm not a huge fan of non-weight bearing. I think that's terrible for healing, and they get a lot of atrophy. So I always have patients touch down weight bearing, but just tell them to be sensible. There are some patients who hate crutches, and then all of a sudden they throw the crutches away at a week. You would never let a patient do that probably for a broken ankle, and this is a broken bone just the same. And like I said, locking plates are way more forgiving. If you can get bone stimulators, they're pulsed, either ultrasound or electromagnetic waves, they actually help. In the US, insurance companies only approve that if you have an established non-union, which is idiotic. So you wait until you have the complication to pay for something that could have avoided the complication. So some patients pay for it. You don't really need it for small corrections in young patients, but if you have an older patient, large correction, going in prophylactically with a bone stim, I think would be good. And last but not least, and this is not a complication, but especially arthroplasty surgeons have said, oh, doing an osteotomy screws up the total knee that comes after, and the total knee will come anyways. So why do you guys screw around with an osteotomy? Let us do the total knee replacement, and it's much better that way anyways. This was a study from Aaron Critch from Mayo. In the US, we say only Mayo can do these studies because if you are in Minnesota, you treat farmers. Farmers never move, so you can do these 20-year follow-up studies. In New York, my average patient moves every 4 years, so finding them can be hard. But this was a study, 25-year follow-up, which is really hard to do anyways, in patients who had bilateral knee replacements and before that had an HTO on one side. Like, to get enough patients with those criteria, long follow-up, bilateral total knees, and an initial unilateral HTO is incredible. They did it. That's sort of a typical patient. That patient actually had a lateral closing wedge. So if anything, those are the ones where you think that a subsequent total knee would be more challenging than the current ones. They found no differences in outcome. So function was the same. So this whole, oh, don't do an HTO because it'll screw up the total knee replacement, not the case, especially not with the modern techniques. And with that, we're finishing up, and I hope by now you have some questions. But I can't say enough good things about osteotomy. If you don't do it, learn it, talk to colleagues, especially if you treat sports patients, and at least in the US, more and more young kids get ACL tears, get bucket handles that don't heal, have to be taken out, and all of a sudden there's this wave of people in their 30s with medial compartment arthritis. Unless you do osteotomies, you don't really have much to offer for these patients. So it's a great option, and if you do it the right way, like everything else, it's safe. I hope I didn't jinx myself, but if you do it carefully, nothing bad will happen. So thanks very much.